Between 20 and 30% of typically developing children experience sleep difficulty in childhood. The percentage of neurodiverse children with considerable sleep problems is even more staggering, at 40 to 80%. On one hand, it is just sobering to consider the impacts of sleep difficulties on children and adolescents. As you'll hear in this week's article review, sleep difficulties are linked with everything from poorer health, education outcomes, and social outcomes. They also exacerbate common conditions like ADHD. But on the other hand, this means that improving sleep is one of the most powerful levers that occupational therapy professionals can address with our clients. I know many of you are already at least touching on this foundational ADL with your clients, but I'm hoping today we will upskill you even further through my conversation with Dr. Amy Gore Hartman. Amy is an occupational therapist and sleep scientist specializing in supporting families with sleep and emotion regulation. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, and I am a licensed occupational therapist. Before we dive into the topic of pediatric sleep and OT, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. So let's walk through this week's article, and then I will patch in Dr. Hartman to talk about the implications of this research for your OT practice. So the article that we are reviewing today is called An Umbrella Review and Meta-Analysis, the efficacy of non-pharmacological interventions for sleep disturbances in children and adolescents. This article comes to us from the Journal of the American Academy of Child and Adolescent Psychiatry, and it was published in 2025. So the article begins with this broad introduction to childhood sleep. Sleep difficulties are linked to poorer health, education, and social outcomes. These may include heightened risk of childhood obesity, cognitive dysfunction, issues with school performance, behavioral and emotional problems, issues with parental caregiver sleep quality of life, and overall functioning. Sleep difficulties can also exacerbate the core symptoms of mental health and neurodevelopmental conditions, such as ADHD. Persistent sleep difficulties may be explained by a diverse set of sleep disorders, but the most common is chronic insomnia. So looking at the current state of treatment, there are some pharmacological treatments available for sleep difficulties, such as melatonin. But the consensus among sleep experts is that non-pharmacological sleep interventions typically should be a first-line approach for addressing sleep difficulties in adolescents and children. While there are several systematic reviews of such non-pharmacological interventions, the reality is that to date, there has not been an overarching quantitative synthesis of available evidence for non-pharmacological sleep interventions across multiple interventions and clinical populations, which leads us into the heart of this paper. The author sought to answer 1. What non-pharmacological interventions for sleep difficulties and disorders have been tested in randomized controlled trials? And 2. What is the efficacy of these interventions across different populations? So what were the author's methods? The author searched multiple databases for recent studies, ultimately incorporating evidence published through January 2024. Data from randomized controlled trials was pooled using an app called Meta-Umbrella. The primary outcomes that they were looking at were subjective and objective sleep parameters. Additional outcomes included child health and functioning and parental sleep and health. The quality of the studies was assessed using the assessment of multiple systematic reviews, and the certainty of the evidence was assessed using the grading of recommendations, assessment, development, and evaluation. So what were their results? This umbrella review included a whopping 93 systematic review and meta-analyses, encompassing a total of 393 randomized controlled trials. The breakdown of clinical populations included sleep problems and disorders in neurotypical children, 39 studies, autism, 15 studies, ADHD, 11 studies, nocturnal enuresis/bedwetting, 6 studies, cerebral palsy, 4 studies, colic, 5 studies, obesity, 3 studies, Down syndrome, 3 studies, cancer, 3 studies, nighttime fears and phobias, 2 studies, migraine and headaches, 2 studies, burns, 2 studies, pain, 1 study, diabetes, 1 study, asthma, 1 study, and depression, 1 study. So as you can hear from this list, sleep interventions have just been studied in a lot of clinical populations within this pediatric umbrella review. Looking at their quantitative synthesis, they were able to synthesize data from 25 of these systematic reviews. These studies focused on typically developing children and adolescents, ADHD, and autism. These studies primarily covered multi-component behavioral interventions, mainly consisting of parent training with psychoeducation, including information on sleep strategies, sleep habit and environment, normal sleep, specific sleep therapies like graduated extinction, and cognitively based behavioral therapy. Specific behavior change techniques included goal setting, action planning, individual management plans, and reward systems. So when the data was pooled from these 25 studies, it was found that these multi-component behavioral systems did show beneficial effects for children who have sleep problems but do not have a formal sleep disorder. The outcomes that they saw these beneficial effects on were nighttime waking, sleep duration, overall sleep disturbance, mood/depression, and maternal sleep quality. For children with a formal diagnosis, mainly insomnia, there were also beneficial effects found for night waking and sleep efficiency. Sleep efficiency was measured both subjectively and with an actigraphy. There were also beneficial effects for sleep onset latency, i.e. the amount of time it takes to fall asleep. For those with ADHD, beneficial effects were also found. These beneficial effects were found for bedtime resistance, night waking, parasomnias such as sleepwalking, night terrors, and sleep-related eating disorders, sleep anxiety, ADHD symptoms, and sleep disturbance and quality of life. For autistic children, there were also beneficial effects found, and this was for sleep disturbance. The effects of these interventions range from small to moderate, and the quality of evidence was rated as low to very low. So headed into their conclusion, among the non-pharmacological interventions for sleep difficulties in youth, only multi-component behavioral interventions are supported by meta-analytic evidence. 2 important takeaways from this conclusion were: there is just an important need to standardize the language around non-pharmacological interventions for sleep. Doing so will allow for an even more detailed exploration of interventions in the future and just allow us to pool even more of the data out there. And second, it was interesting to note that most studies did focus on sleep problems without a co-occurring disorder. But given the high prevalence of sleep problems in individuals with formal diagnoses ranging from anxiety to PTSD, there is a need for more exploration across more clinical populations. Okay, that wraps up our article review. It is always so fun to be able to look at that highest level of evidence, which is this kind of meta-analysis where we get to pool the data from multiple different studies. To me, just seeing the amount of studies out there just really speaks to the importance of sleep. Lots of different disciplines are looking at this, but it's really an area that OTs can thrive in. You heard that list of interventions, and it's just things that OTs are so skilled at. And I am so thankful to have an OT and a researcher on today to talk to us about what this can look like, and that is Amy Gore Hartman, PhD, OTRL. Dr. Hartman is an occupational therapist and PhD trained scientist, examining the role of sleep health in supporting health and daily functioning for neurodivergent children and their families. She is currently working with the REACT lab to examine emotional regulation, caregiver-child relationships, and the sleep health of the family for autistic children and their families. On a personal note, Dr. Hartman is a mother of 2 young children who, for the first 5 years of their lives, were difficult sleepers. As a result, she has tried all the things in search of better sleep as a parent. So without further ado, I will patch Dr. Hartman into this podcast. Welcome to the podcast, Amy. It's great to have you.
Thank you so much for having me.
I am so happy that I found you. I did this previous episode with Dr. Amanda Carroll. It has changed so many things. It literally changed how I think about OT, how I visually see occupational therapy and the treatment areas that we focus on. For me, it personally changed. Like, I set a bedtime after, like, the day after that, and the spillover benefits that I've seen from having a bedtime, like, it's finally helped me do some things that I've been wanting to do for so long, like not watch a show right before bed, not have that glass of wine, not snack because I'm sleeping. Like it's so interesting, like focusing on sleep just had all these spillover benefits, and I couldn't have tackled those things individually. So it's so, I don't know, I'm just sitting here today being like, sleep seems so powerful to me. I don't think we can solve all the world's problems with it, but it feels
But
like,
maybe.
but it feels like we could solve a lot of them. So I'm so excited to learn from you today and look at this pediatric and adolescent like era of sleep and what OTs can do to help there. But before we get to all of that, I just want to learn more about you. And I became interested in this a month ago. How did you become interested in it in your own story?
Yeah. Well, I'm thrilled to follow Dr. Carroll's podcast. It has been wonderful. She and I have collaborated in a Sleepy OT group. And so I'm glad that we're getting the word out because I think it is just so critical, like you said, Sarah. I was a clinician for about 10 years before coming back to grad school to get my PhD and do more research. And as a clinician, I worked solely in pediatrics with neurodivergent children and their families, and really focused on sensory processing, actually. And what I found was, like children would have some really good days, and children would have some really hard days with their sensory processing and engagement and daily occupations. And then so I was practicing for 10 years. Then I had my two daughters, and they are 13 months apart. And my oldest didn't sleep through the night for the first 5 years of her life. And I was like so sleep deprived with these two little babes. And I recognized that my sensory processing was being impacted in my like sleep deprivation. I like couldn't handle the noise. I didn't want to be touched, and my sensory processing doesn't typically impact my daily life, but when I was sleep deprived as an early mom, it absolutely was. And so I started thinking, oh my gosh, I wonder if this is like a hidden thing that's impacting the lives of the kids that I was seeing in the clinic. So I had already been thinking about going back to get my PhD to like add to the research about sensory processing and understanding how we intervene and what's going on in the brain. And then I linked up with my a mentor, Roxana Ben Dixon at the University of Pittsburgh, who was just starting to get into sleep and how it impacts children and adolescents with Duchenne muscular dystrophy. And so I like went on that ride with her. I started training at the Center for Sleep and Circadian Science at Pitt, which is unbeknownst to me, a world-renowned sleep center with some like huge names. So I got to really learn from the psychologists and psychiatrists who are kind of leading sleep and have, for many decades. And then my own research kind of took a path on looking at the family unit and how to support the research or how to support neurodiverse children and their families to get better sleep. So it's been a wild ride. I've tried all of the things with my own family, and I think that makes it really fun to like be with these families, try these new interventions, and also like educate occupational therapists who are boots on the ground to feel confident in addressing sleep. So that's how I got here.
Oh, such a fascinating journey. I do think, again, I just started thinking deeply about sleep like a month ago, but right away it just makes you look back at all the people that you've seen and been like, how big of an impact was sleep at the time? And I wasn't thinking about it. And then I also think like, why was I trying to do these like really complex interventions that required a lot of learning? And I wasn't making sure that they had this foundation um, of sleep. And just like you said too, I think sleep is such an engaging area for OTs because we all experience it ourselves. Like we know how that feels to miss a lot of sleep. A lot of us, as you alluded to, are parents, and we've been through that season. You had a very long season of
Yeah.
missing sleep, and it's just so fascinating how that threaded into your story, and I can imagine it threading into so many OT stories. But not many OTs are at Pitt with their PhD studying this. Tell me more about that. What in particular are you studying? What have you been learning? Like, what opened up for you with this specialization?
Yeah, I mean, I think it's been really a wonderful gift to have this like like specialized knowledge so that I can advocate not only for like the education changes that might need to happen or like the continuing education opportunities for occupational therapists, but I'm like at the table with sleep researchers and sleep clinicians who are not occupational therapists. And the beautiful thing about sleep medicine is that it's relatively young. Like it didn't start I won't give a year. I wanna say it started in the '60s. I might be wrong. But it's young in its research, and there are so many people who struggle with sleep across the lifespan, and there's not enough practitioners to support these people who struggle with sleep. And so the feeling at being like an outsider, an OT in the sleep field is one of like welcoming and like, please come help us. Please share with me like what your unique perspective is on these things. And once I got past like that imposter syndrome of, oh my goodness, I don't know what the suprachiasmatic nucleus is in the brain as I'm sitting down, you know, at the table, but can like ask the questions about, well, what do we know about insufficient sleep and attention or like how it impacts, school or abilities to like process through multiple steps to like do your ADLs, which is sometimes not brought up at those tables because occupational therapists aren't there or other, healthcare providers who are looking at it that way. So it's definitely opened up like an advocacy role for me in those spaces, and then advocating for sleep's importance within OT education, which is really neat. In addition to like the research side of things, where I'm really advocating for the unique aspects that neurodivergent kids experience, like for example, sensory processing differences that might be impacting their sleep that's not addressed in sleep interventions that are currently available now. And so trying to understand what works, what doesn't work, and how can we support these families who have perhaps additional things like additional therapy appointments or additional worries that help them get better sleep to then, build that foundation. I like how you said, I was looking at, fine motor skills or like visual processing, goals and not to address sleep. I feel kind of bad of all the clients that I try, that I worked so hard with and what would have happened if I would have addressed sleep first? Like could we have gotten to those goals quicker? Um, you know, I I think maybe, hopefully.
Per your story, this is such an engaging topic for us. Like it just draws us in as OTs. I love that insight that this is like a really collaborative area and one where we're not like I mean, honestly, we're not like fighting with other disciplines
Yeah.
there's not like a turf war because there's just not enough of us.
Mhm.
And the other, I want to fling us to this article because this is the other thing that just gets me so excited. Like I'm excited about the personal anecdotal things just like I see in my own life. But I look at this research article today and I'm like, we're looking at 93 systematic reviews about these things. Like when I look at other pediatric OT interventions, we're so happy to have one randomized control trial or like we're
Right.
looking at case studies. And so I'm just blown away of like, wow, look at the research here for us to draw on this. I can't emphasize enough to me how much of a standout that this seems. Do you agree with that? And what were your impressions of this article?
Well, I mean, I was so thrilled that you brought this article up. I've never read an umbrella review like this because often you're right, there's not as much, not enough research to
Mhm.
do this type of review. I think that it's interesting in pediatric sleep interventions. Um, Often, if you look at like the populations that are usually tested in these intervention studies, it's either and I think they had like actually a pretty nice sample of different types, different populations of people. But often research like this is done in typically developing kids or kids with depression and anxiety. There's more being done with children with ADHD and also autistic children, which is wonderful. And I know they had a couple other populations in the or in this umbrella review. I love to see that like the overarching outcome or the overarching intervention is this multi-component behavioral
Mhm.
intervention. I mean,
Yep.
how OT because the way that they broke it down was parent training with like sleep strategies and habits and environment and what's normal. I mean, all of those things are so OT. I think there were a couple like sleep specific things like sleep therapy strategies that they mentioned and cognitive behavioral therapy for insomnia. Those are like wonderfully within our realm, but need perhaps a little bit extra training. But all of the behavior change things and goal setting and, reward systems, I feel like we're right up our alley. So as much as I try to take a look at what research is coming out from occupational therapy researchers, I think we absolutely need to keep our eyes open for just generally what the science is and not limit ourselves to just the things that are coming out that OTs are doing.
Another thing that stood out to me from the article was just like the preamble where they say all the things that poor sleep is tied to, and it's very sobering. It's like your physical, social, academic outcomes, um, like downstream the downstream consequences of poor sleep are so, I guess, sobering. And I want to ask you, I guess, a twofold question. One, just how do you like talk about this in a way that isn't how do we talk about this with patients in a way that is palatable? And I also see that and I'm like, that's just like another reason I'm seeing sleep as like the foundational OT treatment because it like impacts so many of our systems. Is that true? And how do we talk about that?
Yeah, I think this is a really interesting idea. So something that came out of a study that I did with pediatric occupational therapy clinicians across the United States was this theme. I had asked them, like, are you talking about sleep and how is it going? One theme that came out of that was really interesting to me was sleep is really intimate. Talking about sleep is really intimate. And I think that it's really critical to approach it that way. I just actually did my sleep lecture and lab at Pitt with the OTD students, and I told them at the end, it's one thing to like know what best practices are and for sleep and for the environment around sleep and how to support these routines. But if you I mean, just like you wouldn't want somebody to come into your life that, like, you're struggling, your kid is especially parents, I feel like, because I was a this parent. You don't want somebody to come in and be like, "You shouldn't have screens before bed. You should have that room dark. Don't turn on that nightlight. You should really get activity during the day, and you should really get sun in the morning to support your circadian rhythm." I might know all those things already. Like, this is especially now, everybody knows about sleep. It's like a hot topic because of all those downstream consequences. And you also don't want somebody to come in and be like, "You need to sleep because you have higher rates of cancer. You have
Yeah.
higher rates of, heart disease. You have higher rates of attention difficulties." The long-term consequences for your child getting insufficient sleep are so significant. So approaching this in more of a conversation, like, "Tell me about how your kid's sleeping." "Oh, yeah. I hear that that's really tough. Do you feel like that's impacting your life as a parent? What about the family? What are some things that, do you think you'd be willing to try some things to support? Is that a priority for you?" We know sleep is really critical, and I'm sure you've heard that. But, that's something that I can help with. Do you want to unpack that a little bit? And just asking those questions and understanding what the family values are, I think is really important. One example that I always think about is co-sleeping. So we know that co-sleeping is, not is kind of frowned upon in Western culture. And is, as a new parent, I heard over and over and over again, "Don't sleep with your baby." And then as like my kids grew up, I heard, "Don't let your kids sleep in your bed. You're creating bad habits. They're never going to be able to fall asleep without you." And that adds like a lot of pressure on me as a parent. In some cultures, in some families, co-sleeping is what they want to do. And like if if there's not now this is different for babies because of the risk, because they don't have, like, independent movement, right? But to a toddler or a young child, if they wanna do that and that's not impacting the parent's life in a negative way, if it's something that's positive and bonding for them, I don't see as a clinician, I don't see an issue with continuing to support that. Now, if it's a behavior that's stemmed from many months or years of struggling with sleep and the parent wants to reclaim their bed for their own, cool. We can work on that. But that like is just one example of, I don't know, is that a problem for you? Is that something that you want to change? Then okay, I can support that. So I don't know if I took us off to in a wrong direction, but that's something that I feel really passionate about.
That's like exactly the answer I needed to hear where like I see all this data and I like want to share it, but I'm hearing you be like this is intimate and it starts with asking questions. And that is something that OTs I know are so skilled at. Like uh I get to talk to OTs across practice areas and I just hear that skill, whether we're working with in cancer rehab or down to, like you said, co-sleeping, like asking questions, just recognizing that we are stepping into like intimate aspects of people's lives. This ties so closely to the next question that I want to ask. And it's reminding me of something that Dr. Amanda Carroll said, where her PA was like, I know all these things about sleep. And like, I know hypothetically what I could do. And that's just not my skill set. So I'm referring to you. But there's another layer there where our doctors don't have a reimbursement avenue for that time of educating and talking about sleep, but we do as OTs. Like this is an ADL. We have just like a reimbursement structure for us to address this. So my question is, how do we get the referrals for sleep? And for kids already on our caseload, can we just be addressing sleep? Like, are there any barriers to just starting to address that with more of our kids?
Yeah, I think so let's start with the second question first. Yes, absolutely. I even if a child comes to you without like a sleep concern as a primary concern, But if like things have come up, like you're working on attention or executive functioning, or you see those sporadic days that they do well or they don't do well, or you get to know the family and know that sleep, like bedtime routine's really tough, or emotion dysregulation is part of the areas in which you're supporting that family, absolutely ask those questions and start doing fact finding. Like you said, OTs have the space and it's within our framework to be addressing sleep. Just like if somebody came in for, say, like sensory processing issues, this like blanket, concern, and you realize, oh, they also have like core instability that's really contributing to the difficulties that you're seeing. You're going to treat the core instability too. So the same thing goes with sleep. As far as getting more referrals, it's almost like a teeter-totter, I think. I've heard from clinicians in my studies and then colleagues who have done similar studies looking at kind of occupational therapists' confidence in addressing sleep. And it's back when we did it, which was 4 or 5 years ago, OTs weren't feeling very confident. And so part of what we need to do is build that confidence and education on like how to address sleep and how to ask those questions and what those interventions are that are available. And then also in the same time advocating for OT's role in addressing sleep with pediatricians, with even like psychologists or psychiatrists who are already getting overwhelmed with the amount of people who need support and they can't give, the wait lists are so long. If they knew that there was a referral source to get people into occupational therapy, I am certain that they would love that. So I think but also, as I'm advocating for OT's role in sleep, I'm like praying that whatever OT that person finds is confident in addressing sleep. And so I think we need to do these simultaneously so that we don't get a ton of people being referred and then OT's not feeling confident. And then it's going to like backtrack and be like, well, no, OTs aren't ready for this. But I also don't want to get us all confident and not have anybody to treat. So it's been a conversation I've had with a lot of colleagues about like, how do we do this in like a quick way? Because like it's needed. There's so many people who need support with sleep, and we are primed to be those people.
Yeah, that two-sided coin where one, we need to upskill our training and be advocating. I do believe those are things that we can tackle simultaneously. That's why I'm just like personally so passionate about thinking of clinical decision support and having these pillar pages for OTs to look at and get just like a menu of options. Because I think once you see, just like in this article, once you see the evidence-based approaches, you're like, oh, I can do that. I just didn't see it together and I didn't have like the menu to choose from. I agree that's something we need to upskill in. I see it as something that we could upskill in quickly because it's all, once you look at it, it's all so familiar already. It's just like that confidence boost is what it feels like to me.
Absolutely.
But thinking concretely about that, I want to ask you about assessment and treatment, beginning with assessment. Dr. Amanda Carroll's episode was so easy because it was like, oh, there's one clear gold standard, this Pittsburgh Sleep Quality Index out of your
Which was
university.
Developed here. Yeah.
Yes. I credit you and other people.
Yeah, thank you. Thank you so much. It's actually my mentor, Dan Bicey, did it as a postdoc. And it's like the most widely used adult sleep questionnaire.
So awesome.
So being his postdoc, I was like, oh man. I wasn't his directly, but I did train under him. And I was like, what are your expectations?
And that's such an awesome, I love that assessment. I can see using it with older kids, but the considerations for elementary, toddler, infants are so different. What's out there for us in the assessment realm?
There are some really good parent-reported questionnaires. So, like the most widely used parent-reported questionnaire is the Child Sleep Habits Questionnaire. There's like also a companion, which is called the Child Report of Sleep Patterns Questionnaire. that aligns very nicely with the children's sleep habits questionnaire that the child does. So you can have the parent and the child, and then you can kind of compare the both, which is kind of neat. For infants, there's the BISC, the Behavior Index of Sleep Quality. I should have looked that up before this.
I'll find
It,
it for us.
yeah, yeah, thanks. That one's really wonderful, but there's a variety of questionnaires. The other thing that I think is really valuable in screening and assessing sleep are sleep diaries. And these are, in essence, just a few questions that a person does or a parent does across the course of like a week or 2 weeks. And there's a consensus sleep diary, which was developed at Pitt, that gives you an example, but really you can use this anyway. Like you can include any questions that you're interested in. So often when I do sleep diaries for my studies and I ask about like what time did you start the bedtime routine? How long did it take? What time did your child start to settle down? What time do you think they fell asleep? Did they wake up in the middle of the night and how long were they awake? And like did you need to help them? What time did they wake up in the morning? And did you have to wake them up or did they wake up on their own? And then I add questions about their mood, their morning mood. And then, so I have them do like part of those questions in the evening and part of those questions in the morning to kind of break it up. But really, like clinically, whatever you're interested in, if you're interested in like figuring out what the pattern is, do they tend to have harder bedtimes on certain days? Is it related to having activities in the evening, or is it related to it being a weekend and maybe things are a little bit more flexible? And that clinically can give you kind of some indication on where to start and where to have that conversation, or it gives you space to just kind of discuss a little bit further with families what's going on. So that's a gold standard. Like that's sleep diaries have been around since the beginning, and they really hung their hat on sleep diaries for a very long time and still do. I mean, it's very frequently the first line of defense when it comes to assessing sleep because it's easy and it gives a really good view on sleep across, a time period, a week or more. And then there's also those clinical interview questions that we've talked about, really trying to uncover not only like what goes on during like maybe the bedtime routine and that settling down period and then overnight, but it's also like as we learn more as occupational therapists about what the circadian rhythm does and our sleep pressure and how do things during the day impact our abilities to like settle down and fall asleep, then you start to get into those questions about the daytime too. So those are things that I also include. You can, wearables are, like watches or sometimes those rings that like Aura Ring and other things are things that some kids come in with, especially the older kids. So if they are wearing something that is collecting sleep data, you can always take a look at that. But I always caution, clinicians or students that I'm teaching, you have to be thoughtful about what type of data is like I want to believe that my Apple Watch can tell me when I'm in deep sleep and not, but it's not really looking at my brain. And my brain's the only way that you can tell that I'm in deep sleep or not. So I think those types of, wearables we take them with caution. And it really is more important, like how the day-to-day occupations are being impacted by sleep than really what the watch says.
Hearing that just loops back for me that how I could see OT's upskilling in this so quickly, because I hear those assessments and they're like patient reported outcome measures. Like we don't have to buy $2,000 assessments and go do trainings around them. They're already in our wheelhouse. We could start tomorrow. The hard part is just wading into this intimate area of people's lives and asking questions. And I do think that's one of our core skill sets, and sounds like the most important part of the assessment area is bringing that skill, which so many of us have already. Thinking of intervention, I look at the interventions listed in this article and I'm like, oh, I could see OTs doing all of this. I'm curious from your perspective, what you would call out here and what you see OTs leveraging. Like, what are I guess, your go-tos? How do you think about this intervention aspect of OT treatment?
I think I like bucket sleep interventions into two parts. The first part is like what supports that child or family at bedtime or like at bedtime and across the night period. So keeping helping them fall asleep and then the other piece is like what are we doing during the day to help support their circadian rhythm. So we know that the circadian rhythm is informed by these like social and environmental time cues or zeitgebers. The strongest one being light. So light really informs like when our wake processes in our brain start and when they stop, like when the sleep processes start. And so our routines during the day can really inform and make our circadian rhythm really robust, which then helps with that bedtiming. So when I think about occupational therapists and the interventions that we can provide, they are in both of those buckets, right? A lot of it is related to routines, getting a consistent routine, but then also making sure that our daytime routine is supportive of that circadian rhythm shift of being alert. So that's like getting that morning light, having activity, monitoring or limiting the light that you get in the evening. And that's often talked about when we talk about screens. And then also, having those supports during the bedtime routine. So whether that for kids is like a picture schedule or just consistency. We around here, when we were really struggling with sleep, we had our smart speakers like start us off because, and this is actually something that a lot of, not a lot, there have been a few families that I've worked with whose the parents also have ADHD and the child has ADHD, and so sometimes it's hard for the parent. They'll say, I don't like bedtime. It's really stressful, really emotional, so I delay. And, it's hard for me to like get going on it. And I know that I need to be consistent with it, but it's something I don't enjoy. And so I need that support. So we use our smart speakers to tell us. So it's not me telling the child to go brush their teeth. It's Google or Alexa or whoever it is, saying it's time to brush your teeth and here are the steps. So I think that that kind of interventions, supporting the routines during the day and supporting that bedtime routine to help, calm. I mean, we haven't even talked about like how do we look at the environment to help us settle down, and then how do we use our sensory systems to help us settle down. Though all of those things are really, really beautifully OT. The other things that were mentioned in the article that are like gold standards are the tenets of cognitive behavioral therapy for insomnia, which I think Dr. Carroll talked a little bit about. And I mean, I feel like if you're really interested as a clinician, really interested into learning more, getting trained in CBTI, just so that you can learn what the tenets are, what the pillars are, so that you can take that into your intervention sessions. A lot of it is stuff that is very much within our realm. It's just a really specific way of looking at things, like stimulus control, which we probably learned at like when we were in OT school when we were learning about, behavior training and things like that. So I highly suggest, getting into that space because it has been shown to be very effective for people who struggle with insomnia or for kids with bedtime difficulties, knowing those principles.
I hear all those things, and part of me is like, on the surface, they sound simple, like set a bedtime, light in the morning, even stimulus control. You're like, as an OT, you're like, yes, totally. It feels like to me what is so valuable about OT, and I think we experience it in our own lives, like it's so hard to change our habits. And I see what OT is being so good at is being like, we have all these things we could do. Like, what's the thing we're ready for now? Like, the bedtime routine might be too hard to even think about. Let's like shift to morning and think about light right now. Like,
Mhm.
is that kind of how you experience it? Like finding the thing where there's like a readiness for change with
Absolutely.
the family and going, then diving into that?
Yes, yeah. We've talked a lot within my research and the intervention that I'm testing about that like family unit piece. And I think that it is really important to see sleep challenges as not only as a 24-hour opportunity to like intervene at different times, like, morning wake up or, bedtime routine, but also as a family unit thing. I mean, I didn't anticipate this, but as I got into my current study that I'm doing with children with ADHD and their families, really seeing how much the parent and child dyad are impacted by each other. Um, and so I think you're right, like, finding that readiness for change space, is really important when you're kind of trying to unpack. I think of it as, like, an activity analysis too. We say sleep is an occupation, so, like, let's break it down into, like, the tasks and the activities that, like, contribute to that. So is it the sleep preparation piece? Are, like, supports needed to, like, you know, co go through all the steps of the bedtime routine, or is it environmental? And and again, just approaching that with, like, care and recognition that each family has its own, values and own, abilities. I think often another thing that I like to highlight, because would hate for an OT to come in and kind of forget this. Not everybody has a bed. Not everybody has a consistent bed. Not everybody has their own room. And that's okay. You can still get good sleep. Although like a foundation of getting good sleep is being in a safe space. So that's really important. A consistent space would be ideal, but in a comfortable space that's dark and cool. And so sometimes, like, I try to check myself when I'm talking about bedtime, not making these assumptions that everybody's like in their own room, in their own bed, with all the stuffies and all the blankets and things
Yeah.
like that. So kind of being thoughtful about how we approach those questions and how we check for readiness for change, without judgment, I think is really important when you work with families.
Mhm. That just segues me so beautifully into this next question of thinking of education itself as one of these powerful interventions that was listed on this list. And you're bringing up, we're like balancing so many things in like thinking about education. One, I'm thinking of like, are you primarily educating the child or the family or together? How do you choose the education approach? And then providing education in a way that is helpful and not full of assumptions or condensation or I don't, yeah. How do you approach this? It feels so delicate. How do you approach it?
Well, so in our intervention, we have an education piece, and I had thought when I built it that I was primarily going to be educating the parents. And like we educate on like why do we sleep? What happens when we sleep? What are the things that we can do for best sleep? Like the typical sleep hygiene things. And then we talk about our like sensory processing and how that can support or hinder sleep. What I found is that parents appreciate the education, especially because the child is there. Because now these parents might be learning something new, and it's possible, but this education is coming from somebody other than the parent to the child.
Yes, yes.
And so I think that that's, like, very valuable because now and also I'm working with kids who are, like, 6 to 13. So even the younger ones, like, this is could be perhaps the first time that they're really being involved in, like, learning about themselves, learning about how they can, like, manipulate different things to, like, get effects in their body, right? Like, "Oh, if I go to" if I try this, use these special, like my snuggly blanket or my weighted stuffed animal or my sound machine. Oh, it does help me, fall asleep better. And so that's been really interesting that the kids are into it. They're wanting to learn, but also parents are appreciative that the children and the parent are both there. We've had multiple times in our study where parents have talked about trying new things on for themselves too to help support their sleep, because it's not uncommon if you have a child. Well, it's definitely not uncommon if you have a child with sleep difficulties. That does often impact the parents' sleep. Even if they're not waking up in the middle of the night, it's just the stress at the bedtime can hinder the parent getting to sleep peacefully and or at a time that they want to. And so that is something that I've learned of, oh, okay, it's really is important to educate the family because it is a family thing, even though we're really targeting the child's sleep. And it's wonderful. I think it's great to be able to provide this education for the kids on a level that they understand, and then also be able to offer, additional information for parents when they are, asking questions or trying to apply the same things to their lives.
Hmm. This is zooming me really high level where I'm just always or lately just chewing so much on this like potential future in value-based care where like you get to treat the dyad because you're a researcher and you have this special setup as a clinician. Sometimes we're like, I have codes for the kids or for the mom or for the
Mhm.
family. And in this value-based care world, I see it freeing us up so much to like be able to look at the dyad together to get out of this like strict code area that we're in. And I'm so excited for that because just hearing like how you're approaching this makes me so excited. And I think we can like shove this into our current fee for service model, but I think there are
Yeah.
models that will lend themselves even more to this in the future. There's one more major area of your brain that I just want to pick as we're getting close to the hour. I know this could be its own podcast, but I wanted the article touched on sleep for autistic kids and kids with ADHD. In your paper, I just read those higher rates of 80% to 40%, so high. What do you want to share with us in this podcast, just particularly about that population and what OTs can be considering?
I think that like these are our kids. These are the kids that we're already
Yes.
seeing. And so I think that if you think about like a lifespan, well, what it feels like as a family to have a child with ADHD or an autistic child and all the supporters that are hopefully within your life. You've got your pediatrician and maybe psychologist, maybe psychiatrist if there's medication management, but all of those people might not have sleep on the front of their minds. Not to say that they can't, but they have other things. And so I feel like as occupational therapists, we also have other things that we're focusing on, supporting that child and the family in their daily occupations. But I do think that we're well situated to be the sleep champion for that family. I think something unique that OTs that I like to lean on when I'm thinking about sleep and our like unique lens is using a model like the PEO, the person environment occupation model by Mary Law. I feel like it allows us to take a broader look because often when I'm talking with my like psychologist and psychiatrist colleagues, they're looking at sleep, like what's happening in their brains while they're sleeping, what's their regularity of falling asleep, or sometimes they talk about daytime alertness, or like how satisfied are they with their sleep. But I think occupational therapists can like, and we need to, with the clients that we're working on who or working with, who have like extra or additional like person factors because of the diagnosis or that they have, or specific environmental like considerations because of, for example, their sensory processing needs, or whatever it might be. The PEO allows us to kind of take that step back and look at sleep as an occupation, or as we've talked about, I believe is like a basic human need, but approach it in a different multi-dimensional way. And so for autistic kids and for children with ADHD, I think if we take that PEO model and think about what are those person factors that we know are unique for these kids compared to kids who don't have neurodivergence. And then what are the environmental factors that we should consider related to this specific family and child? And then we can look at the literature. What do we know about like sleep and autism? What do we know about like the sleep architecture? What happens in the brain that's different for autistic children than children who don't have autism? And then how does that play into how I can best support this family or this child to sleep? So, to kind of bring it back, I do think that OTs are already working with these kids, and our unique lenses can really help support them in a way that could have that overspill effect that you brought us at the very beginning, that could impact a lot of goal areas that we're working on, and the other clinicians that are working and supporting these families are working on.
Yeah, what a joy of OT, or as you have mentioned, some of our sleep collaborators are looking really precisely at sleep and sleep time, and we get to see like, wow, look, this kid is enjoying soccer more or having a better relationship. And yeah, what a satisfying lens that we get to bring to it. I want to do a time travel experiment and plop you back in your shoes as a pediatric OT and pretend you listen to this podcast and you're like, okay, tomorrow when I go to work or within the week, I want to start addressing sleep. What would you recommend? What are the next steps? Like,
Yeah.
what are the practical things we need to do to be ready to address it?
I think I would start with building the relationship with the family. If you're not having the family back in your sessions and you have the capacity and the ability to do that, I would start there, because it's in those conversations that you have that you can start unpacking whether sleep is an area that's impacted, and it's an area that the family or the caregivers are ready to like make some changes. I think too, thinking about kind of maybe doing like a thought exercise to map out what you know already that supports sleep. So what are how do routines support sleep? What would that look like? What are the daytime things and the nighttime things that we already know as occupational therapists that we've talked about in this past hour? I think also making sure to check your own bias or your assumptions about sleep and the environment and the culture and the norms as you're having those conversations. I mean, I say this, but I also don't want everybody to be nervous to talk about these intimate things. I think if you go into these types of conversations, which we do so frequently, right? Like we're the healthcare provider who talks about sex with our clients, so we know how to build these relationships. We know how to handle tough topics. I think just keeping that in mind as we approach this topic that might in our minds be like, well, yeah, everybody sleeps. Let's just talk about it. Let's just try these things. But checking your own bias, and then as you are working with the clients that you have on your caseload about sleep, seeking out continuing education training to like further deepen your knowledge and your skill set. So, one course that I'd love to highlight, and I'm not sure if Amanda did or not, but there is a CBTI course for occupational therapists that Dr. Aaron Aikman at Colorado State University hosts with a couple of his colleagues there, and it's been around for a while, and they do such an amazing job teaching relevant CBTI for OTs specifically. So I definitely would encourage, if it's in your abilities, to go and learn from Aaron and his team. I think that would be such a wonderful thing. There's also other not as many as I'd hope, but other continuing education trainings that you can seek out. I know Dr. Jason Browning and myself separately have done trainings through the Canadians Occupational Therapy Association, and I've done another one that you can watch. I believe, I don't remember who it was. Oh, I've done another training with TheraPro that I think clinicians can access for free, and their training about sleep. And so there's a number of different training opportunities that clinicians can seek out to just deepen their knowledge a little bit or increase that confidence, so that they can start addressing sleep with anybody who comes into their clinic.
Amy, your story, coupled with this research, coupled with just imagining in our OT brain all the spillover benefits of focusing on sleep is so personally exciting for me. Like, I literally think I'm going to look back on my OT career and be like, there was the time before I was thinking about sleep and the time afterwards. Like, I really think it feels that big and that important to me. I want to keep talking about this forever. I hope we have more podcast episodes. But in wrapping our time up today, what do you want to leave us on?
I would love for whoever listens to this podcast just to be excited about impacting sleep in their own lives too, and in the clients that they work with, and doing it with, confidence and care, and compassion. I know that this is our space, and I feel confident that we are the you know, perfect people to be supporting families in this way. So I'm excited to continue this conversation and support anybody who is interested in learning more or being linked up with resources.
Well, you definitely have me excited to be a sleep champion. I so enjoyed this conversation. I'm so appreciative that I found you and for the work that you've been doing. I know all therapists will appreciate it, especially our pediatric therapists. So thank you so much for the time today.
Well, thank you. And thank you so much for having me. It's been a pleasure.
Wow, you all, it is truly such a rare gift to look at an intervention where we have 93 systematic reviews to draw from. The robustness of this evidence, along with just hearing Amy's personal stories, just leaves me convinced that addressing sleep is foundational to OT treatment. To make sure that you are equipped to address sleep in your practice, I am super thankful that Dr. Hartman is willing to create a clinical decision support page for us around sleep problems. This page will provide you with a handy menu of assessments, treatments, and handouts to choose from, and hopefully will serve as a nice complement to our clinical decision support page for adult sleep. So watch for this one on Pediatric Sleep to arrive in the OT Potential Club in May 2025. The OT Potential Club is also where you are going to go to earn a certificate for your time today. So what you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test, and when you pass, we will generate a certificate for your time today. Okay, I just want to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.